like to start by asking you about your early years. So you were born in Sudan, and I wonder if you could tell me a bit about your journey to Canada.
Yeah, so I grew up in Sudan, in the White Nile area. I went to primary school, secondary school in that area, south of Khartoum. And then I went to medical school, which is the University of Khartoum. It's one of the oldest universities in the continent. And it's a rich medical system, so you go straight from high school to medical school, and then I did my internship. And then in the early 90s, that's when I graduated. And of course, at that time, there was a huge exodus from East Africa, from Sudan, from Somalia, from Ethiopia, because of the political situation and some of the changes. And so I came to Canada, and of course, I was very young, fresh out of medical school. There was not a lot of people who were in medicine who look like us or who come from the same region, or Black physicians in general. So I kind of didn't know what to do, who to talk to, but I knew I wanted to learn more. And that's what my life has been. It's been in school, most of it. And so, yeah, I did manage to get into University of Toronto. I did a master degree in immunology at U of T. And that was quite a formative experience for me. And I studied the PhD, but I really wanted to go back to clinical medicine. Again, there was no pathway for us and there was actually quite a lot of hostility in the 90s against what we call IMG, International Medical Graduate. But the pathway was very clear in the US. You just have to get good marks. And so I didn't actually waste any time looking for places. I went to the US, I did my residency at Wayne State University, and then I went to the NIH for a year doing ID fellowship. But then I realized this is not what I wanted to do. But in order to advance further, I had to get a green card. And then I went to work in rural Wisconsin as a hospitalist until I got my green card. And I came back to Wayne State, did my Hematology-Oncology fellowship. I was taken on as an assistant professor. But then at that time, I wanted to come back to Canada, which is actually not a lot of the people who go, who like me, IMG, who go to the US, decide to come back to Canada. But I really wanted to be here because a lot of my community is here. So a lot of detours along the way in order to, join, especially if you want to join as an academic physician here in Canada. I have to say it has its frustrations and the sense that everything is delayed, everything is full of uncertainty and anxiety. But it was actually a great experience because I managed to work in many settings, from rural US to the inner city in Detroit to the HIV clinics at the NIH. So all in all, I would say it was a positive experience. We really learned a lot from it.
So there's so many things that you said that I want to come back to, but I want to just ask you about your practice today, if you could tell me a bit about what it looks like.
So I came back to Canada in 2009. Of course, I was at Queen's University in Kingston. I was doing GI, and then for a long time, I also did CNS, which is brain tumors, and that I didn't expect do that, but it's really one of the best practices I had. Now I am mostly seeing breast cancer patients, and so yeah, I'm an oncologist. You see, early breast cancer people with metastatic disease, and so that's the clinical part of what I do. I also travel a lot to low middle income countries when I can. And so when I go to University of Nairobi, because I was part of the group that started the Medical Oncology Training in 2016, so I would go there and we would see everything. We would round in the hematology oncology floor on 60 patients. So that's kind of a lot of variation. Here also at St. Mike, in the weekends, we round on hematology patients as well.
Nazik, you said something a few moments ago that I think is really important. When you talked about the hostility that you faced and other IMGs faced from the 90s onward. Could you expand a little bit more about what you experienced, what that felt like, and how it affected you?
I can give you an example. For example, when I was doing my master's in immunology at UFT, there were some physicians who were working in the lab as well. And I recall one of them in particular said, "There's no way we will let you guys join the system. It's for us. It's for people who graduated from here." Of course, there was no problem for the hospitals to hire, people like us to clean or be, our personal support workers and stuff like that. Not when there's a lot of privilege. And so, and that's one of the reasons I went. And also, even at the level of immigration, when you get your landed immigrant, a lot of us had to sign that we are not to expect that we would be given jobs. Of course, there are ways around it, and a lot of people managed to get it, but it was more difficult for Black physicians, and especially for us coming from East Africa in particular. And I think it might have changed recently, but it's still more difficult for Black physicians,
And I wonder if for a moment you could talk about the added difficulty of being a Black woman physician, IMG, and what additional barriers are encountered commonly in that situation.
For a lot of Black physicians, it's what we call surprise. I call it surprise at competence. A lot of people don't expect you to be the physician. Even in the U.S., for example, you go into a room with the other colleagues, and the patient will hand you the tray, thinking you're the staff that's going to do other things. And I think it takes time, and you kind of know what to expect. It takes a lot of resilience and in order to practice. However, at the same time, there will always be patients who will appreciate you, and in the end, your learners, and so a lot of us have managed to, get into leadership and continue to practice, but it's not been easy, I would say.
One of the focuses in this series, in addition to just hearing about our members' real life stories and lived experience, is also wellness. And you mentioned the word resilience. And I'm going to say that from my perspective as a long-term medical educator, and also some roles that I have in terms of helping physicians who have trained elsewhere become licensed in their specialties here without restrictions, I have no doubt that IMGs on average are actually more resilient than the average physician. And I'm not sure that's something that is as broadly understood, maybe among other physicians, as it needs to be if they haven't considered that before. I wondered if you could talk for a moment from your perspective about just some of the ways in which you've had to be more resilient to get where you are than you would have been without some of those background circumstances.
So I think, for example, as the immigrant experience itself, you the first few weeks when you arrive, and the first few years, you will, this is a strange environment. Will I ever belong here? Will I ever, even just the first time getting onto the subway, and then of course, the institutions seem to be like big, the huge walls around them, with and so so you really have to have a lot of determination, and then, but the experience of coming all the way over here, there are lots of hurdles. So for example, if you have a passport that's not Canadian, you will be made to stop at the immigration line longer. So you kind of get used to everything. You don't take anything for granted, and that's become part of your life. But then, of course, there's a joy of discovery. There's a every step means a lot to you and to your community, and I think that's where it comes from. That sort of we call resilience, because you've never been in a position of privilege, so that things you expect difficulty in life, and once you won the difficulty, when you get when things go more smoothly, then you actually appreciate that. And then part of it is also your success is also the success for the community. So you're never really an island, you don't have there's no generational wealth to begin with. So you don't have a lot of the middle class trappings.
One thing I find myself thinking about as you talk, during the first part of the pandemic, for all of us, fear for our family's safety was a primary concern. And I know that for you, that was on a completely different level because your family was in Africa and many things had also been evolving at that time. Could you talk a bit about that situation?
Yes. So actually, the first year of the pandemic itself, in December, my mother got sick. She was in Khartoum in Sudan, and it was a very quick illness. And in 3 days, she died. And so we didn't know whether it was malaria or was COVID. And at that time was the peak of the pandemic, that December. So I had to travel. And so travel was very difficult to go get test, and then to go to the airports was a very scary experience. And then coming back, I you have to isolate. So I isolated, and then I got COVID. So and then you have to isolate at home. I think it took like almost 2 to 3 weeks for me to go back to work, and you're alone at that time. People will drop the like food, and you're just grieving, and so there is no connection with people other than by Zoom or by phone. And so it really hit home, how a lot of us are not with our families, and we kind of, and this been shown that there was a recent survey of IMGs in the US, and a lot of them experience the most difficult thing is being away from your family, and that's what would if they were to go back, that's what they would go for, is being with their families. Yes.
Well, you make me think again of the literature on resilience. And again, resilience is so strongly emphasized for our medical students and our residents. And one of many components of resilience, as we both know, is the safety net that a person has beneath them. And so it strikes me as, such an additional challenge that people are so often unaware of if they don't get to know their colleagues or their learners. They don't have the same safety net that many of us, if we have families nearby who can support us with childcare, for example, if a child is sick, or just other, life issues that crop up day to day. That is not a resilience advantage that people have if their family network is living on another continent or in another country.
I think what happens is that you would, we are social creatures, so you would always find, a network of friends, a network of, from your colleagues, and also, the good thing in the last few years is a lot of interconnectivity in the world. So my colleagues who are in Africa, or some people I know in Europe or India, we become much more connected to each other. And I know we hate Zoom and how it changed our lives. Actually, I started using Zoom even before the pandemic, because we were in 2018, we started teaching in the university in Tanzania, the oncology residents there. But then, yeah, so that sort of creates a community. And then when you get to meet people, and it really helps you to, you're grateful for whatever human connection you have, and also your patients. A lot of the time we don't talk about how much our patients actually support us. They do. Like, I mean, when my mother died, I had a lot of support from patients. Even nowadays, despite the difficulty in practicing medicine now, there's new technologies, new medications. Our patients are getting older. Some of them are sicker or they're living longer, which is good, but that creates more workload because then you're seeing more patients in your clinic. And I found, especially after the pandemic, that a lot of the patients would actually express gratitude, and like just my last clinic this week on Wednesday was a big clinic, and of course I'm late because some patients have complications. And every time I go into the room, we say, "I'm sorry, I'm late," and they say, "Oh, we totally understand. We see how busy you are. It's amazing." And sometimes we don't really thank our patients for that. How much they support us.
You've done such incredible work in health equity and also in equity, diversity, inclusion, and belonging from the point of view of medical education and systems design. What can we do better when it comes to supporting Black learners and Black physicians?
I think there's a lot to be done. First of all, being true allies, and I think it's very important to start with understanding the history of medicine, because medicine, a lot of people think of it as just biomedicine, symptoms and science. But medicine, the way it evolved, what sometimes people call Western medicine, but I don't agree with that because medicine has traditions from ancient Egypt. Or that's what we know, and even a lot of the we'll call discoveries in the early 20th century with the boom in biomedicine. Part of it was enabled because institutions like Oxford and the others, where penicillin and all of that discovered, they were supported by money coming from the colony. So everyone has participated in generating that medicine. And so we need to understand, for example, going back to the Flexner report, how Black people were excluded, what happened at Queen's University when the Black students in 1918, I think there were maybe more than 10 of them, they were all expelled. And I think that's kind of a ramification from the Flexner report. And then where are they now? Because you can imagine that, so there's a missing generation. And we have to make sure that we need to do something to recover that, because our physician population should mirror the demographic. So first of all, understanding that the fact that there are missing Black physicians is a construct, and that we need to dismantle it. And that's number one. Number two is, and I see that's happening a lot at the level of the admission. People are understanding is that the physician you want doesn't have to be the one who has all the piano lessons, things that the middle class can afford. Someone who comes from a socioeconomic background cannot afford this, can actually contribute a lot to medicine. We never had the chance to learn instruments or anything like that, but we were able to contribute to medicine, and that's so at the level of admission. And then there is support of the learner in the clinical learning environment. That's very important, so, knowing what microaggression is, supporting the learners in just being the best they can be, providing mentorship, and also support of of Black physicians who are able to go into academic medicine. And this is one of the biggest things, because people talk about the Black tax, and there's nothing actually done to that's my experience. You're expected to contribute to all, and we are happy to, for example, I'm the co-chair for the Network for Advancing Black Learners in Ontario. We have done a lot of work and have recommendations. We do a lot of things with the Black community, but we're giving the same amount of clinical work like everyone else. There's no recognition of that type of work and the amount of work that you need to put into. So what we call really that kind of rare resource, which is academic Black physicians, need to be nurtured, we need to make sure that yes, we have a lot of resilience, I don't deny that, but I think the amount of work that we're asked to do is often not compensated.
You know, the final question I want to ask you, I specifically don't want to ask you what IMGs can do to support their own wellness. I think they've done enough to support their own wellness. What I do want to end with is, what can leaders, program directors, and what can, colleagues of IMGs, how can we support the well-being of our fellow physicians who are international medical graduates?
I think understanding, sometimes IMGs do not talk about their journeys that much. Understanding that journey, understanding that actually that journey mirrors a lot of our patients' journeys, because that's what we see in the clinic. And I think that will go a long way towards, and then understand that there are lots of talents, a lot of other ways of thinking that IMGs can bring. So I think right now with the crisis in family medicine and all of that, that's a talent pool that we never tapped into. I can tell you, like, a lot of the people who went to the US in the 90s would have been now a great addition to the workforce, So we lost many of them, because I know them personally, and I happen to come back, but a lot of them are there. So I think we need to keep an open mind about, expanding the IMG pool, and it's also good for inclusion as well, and to learn from their experiences, from their talents, and this gives us insight into our patients as well. And another way to look at it is that a lot of IMGs also come from areas in the world that have troubled or have conflict. There's a lot of climate refugees. So it would, looking at their experiences, also give us a picture about how the world will live in with all what's going on. A lot of us have stories, my story is unfolding, with my family now becoming refugees in Rwanda, having left Sudan in very difficult ways. So that, and so now when I'm in clinic, I have patients from Ukraine. I see women who are very talented, have enormous potential to give, and of course they struggle with getting into the system, and not only Ukraine, from Eritrea, from Sudan, from elsewhere. So I think that the IMGs will have more insight into that, and I think these experiences need to be recognized, and we need to find better ways to support those who are coming into the system.
Nazik, it has just been an absolute delight to talk to you today. Thank you so much for making time for this conversation.
Well, thank you for asking me to join. I really enjoyed it.